saying share. Now it's visible. So I just go to my first slide, input slideshow. Is that right? Is it clear to you? Is it visible to you?
Clear. Go ahead.
Wonderful. Very good. Thank you very much. Thank you very much, Dr. Yusuf Khan, for the nice introduction. The topic I chose to talk today is a topic that is not mainstream, but it gives a lot of insight into how the type 1 diabetes originates. And if you're one of the cancer physicians who is treating patients for a variety of cancers with checkpoint inhibition treatment, you will realize that type 1 diabetes is a complication, and awareness of this is something that is very important. And from the etiological perspective, it tells us exactly how the type 1 diabetes really starts, and also gives us a clue whether we can go about and do something to prevent type 1 diabetes or beta cell destruction from taking place. So it all started with an interesting story that resulted in the Nobel Prize in Physiology and Medicine in 2018, that was awarded to James Allison and Toshiko Honjo for the discovery of cancer therapy by inhibition of negative immune regulation. So this is what is called as checkpoint inhibition, and many will not understand what these terminologies mean. But it's basically an immunotherapy, and this immunotherapy has found to be astoundingly effective in not only addressing the primary tumor, but also the secondaries that are present elsewhere in the body for a variety of tumors. So just to give a summary of the discovery that helped them win the prize, you realize that cancer immunotherapy is something that has been a challenge for quite some time. So lots of people die from cancer, which we all know. By simulating the inherent ability of our immune system to attack the tumor cells was the one that made the Nobel laureates get that prize for 2018. And it was shared by two people. James Allison studied a known protein that functions as a brake on the immune system. He realized the potential of releasing the brake, thereby unleashing the immune cells to attack tumors. So these brakes are primarily there to prevent immune system from going and attacking your own cells. So by releasing the brake, you can manipulate the immune system to go and attack a target. So this is what he did, and what the protein that he worked on is called a CTLA4. At the same time, somewhere in Japan, Toshiko Honjo was working on another protein, totally different from what James Allison was doing. And that protein called, you will see, is a protein that helps in making the T cells activated. So they have done this work independently, and both of them seem to have worked very well in fighting cancer, especially killing the cancer cells. So Allison and Honjo showed how different strategies for inhibiting the brakes on the immune system can be used to treat cancer. So this was a seminal discovery that led them to receive the Nobel Prize in 2018. So why am I not able to move my slide? Okay, so our immune system, how does it get engaged for cancer treatment? This was the primary focus for their discovery. So there are so many varieties of cancers, and all these cancers have different forms of treatment. And some of the treatment that had won the prizes include chemotherapy and bone marrow transplantation, etc. So, however, the advanced cancer remains immensely difficult to treat, and novel therapeutic strategies are desperately needed. And this is where the immunotherapy of cancer becomes very important. I need to describe a little bit about this cancer before I go and start talking about how the treatment for cancers is affecting beta cells and resulting in type 1 diabetes. So it was very late in the 19th century as well as the beginning of 20th century. The concept of activation of immune system might have been considered as a strategy for attacking tumor cells. So this work had continuously happened and progressed to result in several discoveries, especially manipulating the dendritic cells is one, and interfering with some of the immune mechanisms so that you can make the dormant activated cells to become killer cells. So there are something called accelerators and brakes in our immune system. These are all designed to help you decide what is self and non-self, and not to attack self and attack the non-self. What is non-self is something that is coming outside the body. What is self is those proteins that are present in your body that your immune system should not go and attack. So this is how it is. The T cells, which is a type of white cells, are key players in the defense. T cells are shown to have receptors that bind to structures recognized as non-self, and such interactions trigger an immune system to engage in the defense. So the T cells go and attack those cells and try to eliminate the cells by recruiting more T cells. But additional protein act as T cell accelerators are also required to trigger a full-blown immune response, which I show it in a slide, in the next slide. So many scientists have contributed to this important basic research. But this intricate balance between the accelerators and brakes are essential for the tight control of the immune system so that your body does not end up being attacked by your own immune cells. So in this picture, what you can see on the top left is the CTLA4, how the antigen presenting cell engages with the T cell. And you have a cancer cell, and this is the brake. And how this brake is released is what I'm going to tell you. So there is a CTLA4 that is engaging with B7 here in this interaction between T cell and antigen presenting cell. So if you go and block the interaction by having an antibody against anti-CTLA4, what happens is the resultant T cell here gets activated, and that T cell goes and engages the tumor cell and destroys the tumor cell. So what is the release of the brake is going and blocking the CTLA4 with an antibody. At the same time, PD1 is another protein that is expressed on the T cells. This PD1 again engages with PD1 ligand here, and this interaction is perfectly normal, and the T cells do not get activated and nothing happens. Whereas if you block the PD1 with anti-PD1 antibody or block the PD1 ligand with anti-PD1 ligand antibody, then this interaction is interrupted. With the results, the T cells get activated, and these T cells target the cancer cells and kill the cancer cells. So this is like releasing the brake so that the T cells, which were so longer silent, is no longer silent, so that they could be activated to go and attack the tumor cells. Here, the tumor cells are the target, but unfortunately, some other cells can also become a target if they also express similar proteins. So a new principle for immunotherapy was discovered by Jim Allison and Toshiko Honjo. So what happened was that the Jim Allison was studying the T cell protein called CTLA4. He was one of the several scientists who made the observation that CTLA4 functions as a brake for T cells. So what he has done is he has already cloned and produced CTLA4 antibodies in his lab. So that helped him to use that antibody in several experiments to show that the CTLA4 blockade could disengage the T cell brake and unleash the immune system to attack the cancer cell. This was something that he discovered somewhere around 2010, 2011. And this had brought enormous change in the way you treat cancer patients, that you can eliminate cancer from your body. And now they're testing on a variety of cancers and also a combination of anti-CTLA4 antibodies with anti-PD1 or anti-PD1 ligand antibodies. So Allison and co-workers performed the first experiment in 1994. The mice with cancer had been cured by treatment with antibodies that inhibit the brake and unlock the anti-tumor activity. So promising results soon emerged from several groups, and in 2010, an important clinical study showed striking effects in patients with advanced melanoma, a type of skin cancer. Several patients, signs of remaining cancer disappear. Such remarkable results had never been seen before in this patient group. So this was a major advance in cancer immunotherapy. But if you look at PD1, the PD1 is also expressed on the surface of the T cells. Determined to unravel it solely, Toshiko Honjo meticulously explored the function of this series. He came from Kyoto University, and the results showed that the PD1, similar to CTLA4, functions as a T cell brake. And if you block the PD1, you release the brake, and it goes and attacks the cancer cells to destroy the cancer cells. So he performed animal experiments and showed promising results in fighting against cancer. And this paved the way for him to use the anti-PD1 antibody for treatment of patients with a variety of cancers. And he did his clinical studies in 2012. And the key study demonstrated clear efficacy in the treatment of patients with different types of cancers. So now it is also possible to use the combination of CTLA-4 and anti-PD-1 antibodies in order to treat patients with difficult cancers. So this immune checkpoint therapy for cancer today and in the future has become a hallmark. And this has transformed the way the cancer immunotherapy happens. So this is called immune checkpoint inhibition treatment or immune checkpoint therapy, as they would like to call it. Similar to other cancer therapies, adverse effects are always seen. So what are the adverse effects for this particular treatment? And many of the adverse effects can have a serious and life-threatening complications as well. They're all caused by overactive immune response leading to autoimmune reactions, but are usually manageable. So of the true treatment strategies, checkpoint therapy against PD-1 was proven to be more effective, and positive results are being observed in several types of cancer, including lung cancer, renal cancer, lymphoma, and melanoma. So between the two, treatment with anti-PD-1 alone is quite effective compared to CTLA alone. So many new clinical studies show that the combination therapy targeting both CTLA-4 and PD-1 with anti-CTLA-4 antibodies and anti-PD-1 antibodies has been found to be more effective, especially when it was demonstrated in patients who had melanoma. So this is the major contribution by Allison and Honjo that inspired efforts to combine different strategies. And now this treatment is mainstream in oncology practice, and lots of patients are being treated with this particular treatment. So for more than 100 years, scientists had attempted to engage the immune system in fight against the cancer until the seminal discoveries by these two laureates progressed to clinical development that was modest, and checkpoint therapy has now revolutionized cancer treatment and has fundamentally changed the way we view the cancer, how cancer could be managed. So what are all the important side effects? This is where type 1 diabetes comes into the picture. So the checkpoint inhibition and immune-related adverse events, this is where we need to a little bit focus to understand what kind of damage this particular treatment against cancer cell can do to other cells in the body. So here is in a cartoon that shows tumor-specific T cell engaging a tumor cell. You have a T cell receptor, you have an antigen, which is a tumor antigen and the MHC. You have CTLA-4 and you have PD-1. The idea is to block the PD-1 with anti-PD-1 antibody and CTLA-4 with anti-CTLA-4 antibody. When this blocking is made, the T cells become very active to destroy the tumor cells. So anti-PD-1 antibody has been effectively used in many of these cancers like melanoma and non-small cell lung cancer, renal cell carcinoma, and many of these cancers mentioned here. Whereas if you look at other CTLA-4 inhibitors, these are all the names that have been given to these antibodies. Ipilimumab, tremelimumab, it's so difficult to pronounce, but they are all pretty effective. And PD-1 inhibitors are called nivolumab, pembrolizumab, pidilizumab, etc. And you have PD-1 ligand inhibitors, and you have some of these names that are appearing here. So these are for the anti-PD-1 antibodies produced by different companies. And these are anti-CTLA-4 antibodies. These are the cancer indication where these treatments work. And these are all the different antibodies that are being tested. So the mechanism of action would be expected to lead immune-related adverse events. Endocrine organs, especially the pituitary, thyroid, adrenal, and beta cells are prime targets. But who are all the people who are likely to get this complication? The immune-related adverse effects. Somebody who has some kind of an autoimmunity already existing in their family, whatever autoimmune disease that it can be. But also a particular HLA that if they carry, it increases the chance of this particular immune-related adverse event to happen. So what is really happening here? The clinical features of diabetes induced by checkpoint inhibitors. So there is a new onset diabetes, immaterial of age. It could be an elderly or a dramatic increase in insulin requirement in patient with known diabetes. If this patient with type 2 diabetes were to have cancer, and if that cancer is treated with checkpoint inhibitor treatment, the type 2 diabetes get worse. So the incidence of developing type 1 diabetes in patients who are treated with checkpoint is 1% of all patients who are treated. From the time you treat, if you look at the median value, by within 20 weeks, you can develop complete destruction of beta cells and result in diabetes development to happen. So when they studied collection of patients, it was frequently present, the patients frequently present with diabetic ketoacidosis, which was observed in 7 out of 17 patients. And the average HbA1c is not very high because the onset of disease is much shorter before the HbA1c can really go up. They may or may not have antibodies, but majority have autoantibodies to both GAD and as well as IA2. But there is also inflammation of the pancreas, where pancreatic enzymes are increased in 42% of patients. And other autoimmune endocrinopathies are also observed in those patients who develop diabetes. So that include the thyroid dysfunction and hypophysitis. And many of these patients who develop diabetes do not have family history of autoimmune diabetes, but they may have a family history of some other autoimmune disease. So it rapidly progresses to undetectable levels. I'll show some graphs on how quickly it can progress, where there is total destruction of beta cells. It does not appear that steroids will prevent. And recovery is uncommon. Once you stop the treatment, the beta cells don't get back to life. Once they are dead, they are dead. That's the unfortunate situation. So you are confronted with a situation where would you like to have cancer that might kill you, or you would like to have diabetes that you can treat and make the patient alive. So the problem is seen predominantly in anti-PD-1 and anti-PD-1 ligand antibody treatment, either alone or in combination, but a little bit lesser in patients who are treated with anti-CTLA4 antibodies. So when you look at some of these patients who are treated with checkpoint inhibitors, the development of diabetes was 9 out of 25 had GAD antibodies, 5 out of 24 had IA2 antibodies, and this was the numbers observed for zinc transporter antibodies. But the number of people who were treated and they did not develop diabetes, having these antibodies is really, really small. But if you look at combination of antibodies, nearly 40% of the patients who have diabetes have autoantibodies. But it also takes some time for the antibodies to develop because the disease development is faster than the antibody development is taking place. That is why not many patients are seen to be positive in such a short span of time. When you look at the HLA frequencies on these patients who were treated with checkpoint inhibition that induced type 1 diabetes, these patients predominantly 76% of them had DR4 HLA, but out of the 16, 6 had DQ8 in addition to DR4. So these are clearly susceptible HLA for autoimmune diabetes. The patient without diabetes, they had very low frequency of DR3 and DR4. So there is certain level of influence this HLA molecule does in deciding who should develop type 1 diabetes and who should not, and those treated with checkpoint inhibition treatment. So when you look at these cases, there's a particular case that is described in this paper, a case of pembrolizumab induced type 1 diabetes mellitus and discussion of immune checkpoint inhibitor induced type 1 diabetes. So what happens here? So immune checkpoint inhibitors such as pembrolizumab, ipilimumab, nivolumab, now they're all FDA approved for treatment of several types of cancer and has been associated with immune-related adverse effects. What is reported is they induce development of type 1 diabetes mellitus. So this is the worry. So if you are a cancer physician and if you are treating these patients with some of these checkpoint inhibitors, you should alert the patients and also the resident doctors to monitor blood glucose in these patients. So this is a very important parameter that people should have in mind. So how does it work? This is when the treatment starts with the checkpoint inhibition therapy. And if you go over a period of 6 months, 6 weeks of treatment, you have total loss of beta cells and the C-peptide level is low. And this is where you need to really start the insulin treatment. That is 6 weeks from the time you start the immune therapy. And you can see that GAD antibody develops within 6 weeks. And a little later, 2 weeks later, the IA2 antibodies develop. So this is the rapidity with which the beta cell destruction takes place and autoimmune diabetes develops And this is total destruction of beta cells. The only analogous situation that you can find is diabetes called fulminant diabetes, which is predominantly seen in Japan and many Asian countries, which has a similar progress and rapid onset and complete destruction of beta cells. And we also have a case where checkpoint inhibition therapy has been given with fulminant diabetes as an outcome. So this is how the rapidity, you can imagine in 6 weeks time, your HbA1c is not going to get altered so much. But if you are not aware of this, this is going to be a problem. And many of these patients getting treated with checkpoint inhibition therapy will end up in your clinic with diabetic ketoacidosis. If they end up in an emergency and you don't even know whether they are being treated for cancer with antibodies, you are going to miss some of the important facts in terms of what you should do. So the checkpoint inhibition therapy associated with type 1 diabetes, when you look at the literature, in this particular case, they report rapid onset insulin-dependent type 1 diabetes in the administration of nivolumab, a fully human monoclonal antibody against PD-1. So you will realize that much of these complications seems to arise only if you are treating with anti-PD-1 antibodies and anti-PD-1 ligand antibodies. When you look at all the cases that had developed type 1 diabetes in this particular scenario, 42 cases had developed type 1 diabetes as of 2018. That is when it was published. And you can see the variety of treatment that were given to these patients. And the gender distribution is more or less common. But many of these patients are elderly. This is very strange that a 65-year-old with a cancer getting treated with checkpoint inhibition will develop type 1 diabetes with total destruction of beta. So age is not a limitation here on who will develop, who will not develop. And autoantibody positivity varies because the time it takes to develop autoantibodies is little longer than 6 weeks by the time when the disease happens. So how does it work? If you have a tumor cell here that expresses PD ligand 1 and MSC, and if the T cells interact with them, there is certain level of tolerance. And this tolerance is the one that prevents the immune system from attacking the tumor cells. But if you were to block the PD-1 receptor with anti-PD-1 antibodies or PD-1 ligand with anti-PD-1 ligand antibodies, this interaction and friendliness goes away and this T cell becomes activated and they start attacking the tumor cells. But the unfortunate situation is if you compare this, instead of tumor cells, if you have a pancreatic beta cells, the pancreatic beta cells also express CTLA4 and PD ligand 1. And this is where, if you treat a cancer patient, the anti-PD-1 antibody that activates the T cells allows the T cells to go and destroy the pancreatic beta cells also. This is an unfortunate complication. So it boils down to, is your life important? That you want to save the life from cancer? Or you can have diabetes that you can manage. So this is the proposal of screening and treatment algorithm for all physicians who may have to be aware that this is a complication that can happen in patients treated with checkpoint inhibition therapy. So you'll have to educate the patients under treatment that hyperglycemic symptoms and diabetic ketoacidosis are quite likely, so they should watch for it. So there should be an extra vigilance for patients with history of autoimmune disease. This kind of awareness that needs to be shared by the cancer physician. Then you need to ask for blood glucose monitoring. Patients with an autoimmune disease provide a glucometer. In all, measure fasting plasma glucose instead of random plasma glucose. And HbA1c can be tested, but it might not be as indicative of plasma glucose. So you confirm the diagnosis, you will realize that C-peptide levels are very low. You can measure antibodies and see. You can also have HLA typing, but this is not really going to help you in your decision making or in terms of identifying that these patients are developing type 1 diabetes secondary to the treatment of cancer. So once you know, then you have to start multiple injection of insulin therapy because no oral hypoglycemic agents are going to work as the beta cells are completely gone. So this problem affects not everybody. It doesn't matter what background you come from. This is the anti-PD-1 antibody treatment in a Chinese patient that had resulted in autoimmune diabetes. And if you look at a patient, painless thyroiditis and fulminant type 1 diabetes in a patient treated with immune checkpoint inhibitor. So not just diabetes, other endocrine organs are also affected. And this is something that one needs to remember, not just look for type 1 diabetes, please look for other autoimmune endocrinopathies as well. It's quite possible that the patient will suddenly present to the emergency with the diabetic ketoacidosis. At that time, eliciting history and getting the information about the treatment for cancer, it will be very valuable for you to know what is the real cause of the disease so that the appropriate treatment can be initiated. Please remember, this is not something that will happen only in the young people. It can happen in 70-year-old. It can happen even in 80-year-old, immaterial of what gender they belong to, as long as they are treated with checkpoint inhibition, because cancer is something that can occur at any age groups, depending on what kind of cancer you're talking about. So don't expect that type 1 diabetes is something in this situation can occur in younger individuals only. It's also possible somebody who already has a type 2 diabetes and cancer, when they are treated with immune checkpoint, this same people, if they happen to be DR4 positive or DQ8 positive, they can also have all their beta cells knocked out. And there are case reports suggesting that it has happened in type 2 diabetic patients who become type 1 diabetic because of total loss of beta cells. So this is the story of unintended consequence of treatment of cancer, where type 1 diabetes is the resultant complication. But there is something interesting and strange that is happening that you have no idea what is happening here. When these patients, this particular guy was treated with checkpoint inhibition therapy, he did not develop diabetes. That was not the outcome, but all his gray hairs became black hairs. So there is a repigmentation of hair taking place during the immunotherapy treatment with the anti-PD-1 and anti-PD-1 antibodies. This is still a gray area, and we have no clue how this treatment is influencing color change in the hair from what was gray and back to black. So hopefully in the future, we will understand what this, how this happens. And maybe if we can tease out and make this alone, you can have a lot of people look younger as they get older. So in conclusion, the checkpoint inhibitors can induce insulin-dependent diabetes in patients with prior history of diabetes or even without prior history of diabetes. The incidence is close to 1%, but there is a bias towards patients who are treated with anti-PD-1 antibody and anti-PD-1 ligand antibody, or alone or in combination. The clinical features include pancreatitis in about half of them, which I showed in one of the results. So there are changes in the beta cells in response to immune assault. When exposed to inflammatory cytokines, they express molecules that are associated with immune regulation. And this is where the problem comes. In addition, pathways leading to post-translational modification of proteins are also induced. So PD ligand 1 identifies beta cell responding to immune assault and inflammatory cytokines. PD ligand 1 beta cells are fragile and are more susceptible to killing than PD ligand 1 negative beta cells. So there are beta cells that do not express PD ligand 1 also. These observations suggest a mechanism whereby non-specific inflammatory mediators may render beta cells susceptible to killing. Now this opens a lot of questions. Is the immune cells are the ones that are killing the beta cells? Or is the beta cells that are becoming susceptible and making themselves vulnerable to death? So some time ago, maybe 30, 35 years ago, there was a fantastic paper that was published by Franco Botarso, which said in type 1 diabetes, is it homicide or suicide? If you are going to treat patients with cancer immunotherapy, and if your cancer is getting treated, and if these antibodies are responsible for triggering the T cells to kill the beta cells, this probably is what you will call it homicide. Whereas if the beta cells are becoming vulnerable, then the situation is different. So it is more likely to be suicide. So this particular intervention for cancer that resulted in type 1 diabetes has opened a lot of ideas on how the beta cells are dying. Can we use this to prevent beta cells from dying? What can you do if you have an anti-antibody? For instance, if you have antibody to PD ligand 1 that can kill the cancer cells, and maybe, I don't know, we need to figure out in a clinical trial to see anti-antibody to PD ligand 1. Would that save the beta cells? But PD ligand 1, it is PD refers to programmed cell death. And PD ligand 1 is very important here. And this PD ligand 1 expression becomes important. Why should the beta cells express? So they are becoming vulnerable to death. And this is where it becomes important to identify beta cells are the ones that are responsible for dying, where we can call it a suicide of beta cells. So all these debates, we will get more answers as we move along, because this particular development of diabetes to cancer is only there for the past 4 or 5 years, and information is becoming more and more available. So with this, I conclude my presentation. Just to show you, if you're interested in immunology of diabetes, I've edited several volumes on immunology of diabetes. You're most welcome to search for them and find them and look at all the articles that are published there. If anybody who is in the Facebook, they're most welcome to subscribe or like the Thoughts on Diabetes, where you get a lot of information on the new publications and new research that are happening not only in type 1 diabetes, but also in other diseases. So with this, I conclude my presentation, and I'll be happy to take any questions.